wanted to start off today with a couple of stories. And a couple of stories about some of the new things that are happening today with open data. The first one is a story about two guys in New York who are working to disrupt healthcare. Their names are Mike Galbo and Russ Graney, and their story's kind of interesting. They both had very similar but separate experiences. Basically, they both had family members who went into the hospital for outpatient procedures who required post-acute care after those procedures. When they were discharged from the hospital, both Mike and Russ were handed essentially the same thing, a photocopied sheet of paper with a list of 30 post-acute care facilities, their addresses and phone numbers, that they could then pick and choose from to decide where they should send their family members. So they did what pretty much any rational individual would do at that point, which is pick the one that was closest to their house so that it was easy for them to get back and forth to take care of their family member. Turned out that both of those post-acute care facilities that they sent their family members to had a history of various issues over medication in one case, other things in the other case. It also turns out that all of that information was out there. It was public. It was actually collected by the Department of Health and Human Services. And it just wasn't presented to them in a way that they could make use of it. So Mike and Russ actually got together and started a company to solve this problem. They called the company Aiden. And what they do is basically take a ton of open data, not just from HHS, but from lots of different places, and put it together in a interesting and useful interface that both discharge planners at hospitals and caregivers can actually access to try to make decisions in a better way about what facilities to send their family members or loved ones or people that they're responsible for to. And in doing so, actually have begun to really disrupt the post-acute care world, because all of a sudden, these guys are going to be incentivized to do things that are different than just being proximally located to somebody's house. So that's Mike and Russ. Another story. There are these two guys actually who are fellow graduates from the University of Chicago Computer Science program, so I have a little bit of Chicago pride here. But these guys, Joe Flesch and Declan Fry, after they graduated, they were working for, they were basically started a consulting company working to build websites and databases and applications for various companies out there. When in 2012, they were contacted by a small nonprofit to help them create an app to organize all of the information that they had about community services. And I know many of you are in this world, and so you know that this is a very fragmented universe. The data is not standardized. It's not accessible in a consistent way across the board. But they built this site, and it was incredibly successful, this app. And they realized that they could use their skills, these web skills and development skills, to actually build something meaningful. And so, again, using open health data, this time they used data from ACF, the Administration for Children and Families. They used Head Start data and a bunch of other things. They built a company called Purple Binder out of Chicago. And this company basically focuses on helping social workers and community workers provide access to people or to connect people with the resources that they need and to help provide this information for the first time in a consistent and compelling way. So here's the best part, at least to me. You've got Mike and Russ, and you've got Joe and Declan. And none of these guys actually knew anything about healthcare or human services before they got involved in this stuff, beyond any of these personal experiences they had. And for me, this is a trend that really fascinates me. It's something that I've been kind of fascinated by for a while, which is that the people who have the potential to disrupt industries, or the ones who are actually doing it, tend to be the ones who actually don't know much about those industries in the first place. If you talk to Janice Fries or Nicholas Zenstrom from Skype, David Friedberg from the Climate Corporation, even Jeff Bezos, in a sense, for Amazon, none of those folks had any knowledge of those industries that they were going into before they went into them. And they ended up totally changing the way these things worked. And if you talk to them now, many of them will tell you that if they had known now what they didn't know then, they never would have done it, because these things are so complex, and there are a million people out there who will tell you why you can't do a million different things. But these are guys who are jumping in and actually changing things. So the fact that this is happening in healthcare, and the fact that it's happening in human services, I mean, look, healthcare is a $2.8 trillion industry in this country. It's 18% of our GDP, and it's only growing, is nothing really but encouraging to me. So At HHS, some of you might know this, I have two titles. One is Chief Technology Officer, the other one is Entrepreneur in Residence. And I tend to focus on this EIR role a little bit more, mainly because even though I am a technologist by sort of background and training and a huge geek at heart, one of the things that I've realized over time is that technology alone is not going to be the thing that solves problems. More often, it's it can be a catalyst or an enabler or an accelerant, but more often it's going to be actual culture change or process change. It's going to really make things stick, with technology kind of layered in to help things along. And so, in many ways, my role is not necessarily to sort of take technology and do interesting things at HHS with it. My role is really to help everybody at the department, and in many cases in the outside world, improve on the way that we deliver on this transformation of the health and human services ecosystem. And as part of that, we're really looking for disruptors, both inside the organization and outside the organization. And I believe that this is necessary right now because if you think about it, we're actually going through one of the most fundamental shifts in our history since the creation probably of Medicare and Medicaid in '65. And really for the past 3 years, this whole health and human services ecosystem has been in a state of flux, primarily due to the passage of the Affordable Care Act in 2010. And there are a lot of reasons for this that go beyond just the marketplaces, which is what we hear about all the time, right? I mean, we're not living in a world anymore where 20% of insurance premiums can go to administrative costs instead of direct care. We're not living in a world anymore where preventative care services, vaccinations, breast cancer screenings, things like that, aren't an essential part of the health services that are provided to people. I think I can finally say this and be true. We're not living in a system anymore where people can't shop for insurance on an apples-to-apples basis, right? You guys in California did a great job, by the way. Kudos to you. What we are living in, though, I believe, is a healthcare and human services ecosystem where data is fundamentally driving this change. It's changing how we interact with, how we experience, and how we manage this world. And it's fueling changes like payment reform. We all know that we live in a world of fee-for-service medicine right now. This is fundamentally shifting to a value-based ecosystem where we start to actually compensate people for keeping people healthy instead of treating them when they're sick. We're changing how Americans in general, the average person, interacts with and manages their own health, right? We have all kinds of devices. We have all kinds of things that people can leverage now to actually work on collecting information and acting on that data. And it's also changing how physicians provide care, taking the data that we collect and integrating that into a daily routine, looking at predictive analytics to decide the best treatment regimen. I mean, this stuff, we're just at the tip of the iceberg here. And then also, I really think that we're actually just getting into how data is changing how social programs actually provide their services. So literally last week, I saw a demo from a group of folks at ACF who are experimenting. This is a really cool thing. I guess, how many of you are familiar with SACWIS stuff? Child welfare, okay, I figured many of you. So how many of you have seen it's essentially a Word report with a bunch of Excel spreadsheets that comes out, I think, once a month or once every couple of months from ACF that details how SACWIS or child welfare programs are performed across different states and counties and things like that. Have you guys seen this? A few of you? So this is like it's a Word document, okay, with lots of numbers and words, and it's not very useful in terms of actually managing a program. So these guys at ACF literally in just 3 months and with a tiny amount of money were able to take this data and visualize this using software, off-the-shelf software, in an absolutely fundamentally different way that's going to enable people both in the HHS regions and in the states to manage these programs in a brand new fashion. And it's going to change the way these child welfare programs actually work. And this is just something they did in a couple of months. People who had no experience with the software, no experience with data analysis, were actually able to take this information out of a Word document and put it into an engine where they could actually get some actionable insight from it. So this stuff is amazing, right? It's just starting to change. In 2011, some of you might know this, McKinsey released a report that said that this idea of open data has the potential to remove billions and billions of dollars of cost from the healthcare ecosystem, but also significantly increase the quality of care. And so we have all of this stuff, right? We have things that are actually happening, data points that we can point to. We've got analysts that are putting reports together. And I think it's pretty clear, see the same value in this stuff. And so the question is, what are we doing about it? Well, that's really what I'm here to tell you about. So most of you know, I'm assuming, that for the last few years, we've been working on this thing called the Health Data Initiative at the department. And this is really, in a nutshell, this movement, or this initiative is a movement which is designed to, first of all, make health and human services data openly available. Secondly, to take that open data and disseminate it as far across the ecosystem as we can. And then third, continuously educate people out there about the value of this data. Help them understand what they can do with it, take new ideas, celebrate them, show people what's happening, and kind of get the word out. So the first step, obviously, in this whole process is to find the data and make it open and make it available. And so the last 3 years have really been spent, in many respects, focusing on liberating any and all data that we can find. Some of you might know this story, but it really started with 45 people in a room at the Institute of Medicine in 2010, and essentially a pile of 30 data sets on the table, and a challenge, which basically said, listen, take these 30 data sets, go away, come back in 90 days and show us what you could do. And at the end of 90 days, these people came back, and there were 24 different applications that people had built. You know, not terribly fancy, but different, new, right? Things that had never existed before had taken this data and created something brand new. And that was actually the first Health Data Palooza, that sort of 45 people regathering and showing off what they did. If you kind of fast forward to look at last year's Data Palooza in DC, in June, we had over 2,000 people there. It was a massive room, packed. It was like one of the most amazing things I've ever seen. This year, Dwayne, how many people were we expecting? So it keeps growing, right? This Data Palooza, I think, what is it, June 1st and 3rd in DC? Second and third. So I'm putting a plug in now. You guys should all go. It's an amazing event. But I think what we can see from this trend is that in a lot of ways, we've really successfully changed the default setting, especially within federal HHS, from closed data to open data. And a great example of this, how many of you guys remember last year when CMS released the inpatient and outpatient hospital charge data? So some of you remember that. That was a pretty big deal. Now, the data itself, it's interesting. It's interesting data. It's not terribly useful for sort of, you know, evaluating how the system actually works and making significant change. But what it is useful is in doing is, first of all, proving that we can put potentially controversial data out there and seeing interesting things happen. There were all kinds of front page articles on, you know, major newspapers visualizing. My favorite one was in the Times. It was like a satellite image of a 2-block radius, or I guess a little bit bigger than that, in Miami, where one hospital was charging something like $95,000 for a procedure, and a hospital right next door was charging $16,000 for a procedure, right? And there's no rhyme or reason to this, and the data actually points that out. But what's cool is that when we released that data, we had a huge response, not just from the press, but from the public. That data set was downloaded over 200,000 times in the first week. Actually, one of my favorite parts about that was that if you guys saw The Daily Show right around that time, Jon Stewart actually featured this. Like, he talked about a data set that we released and actually talked about it positively, which is one of the first times I've ever heard Jon Stewart say anything positive about government. And so that made me pretty happy. But actually, even better than that was a conversation that I was having with Bill Corr, the Deputy Secretary at HHS, a couple of days later. And I was telling him the statistic about how this data set had been downloaded 200,000 times. And he looked me straight in the eye and he said, "Bryan, that's great, but what's next?" And the fact that he actually said that, right? The fact that he didn't, you know, stop and say, "Oh, well, great, you know, we should celebrate this and all this stuff." He actually wants to do more. I think says almost everything there is to say about the how the leadership at HHS really views this idea of getting information and data out there. So we are never ones to pass up an opportunity like having the Deputy Secretary say, "Go forth and gather data." And so we sort of hit the gas pedal and started running with this. One of the things that we've recently released, I don't know how many of you guys might or might not have seen this. We recently put out what I would call the first ever sort of open data execution plan. I hesitate to use the word strategic plan because I kind of hate strategic plans. They don't really get you anywhere, but we have an execution plan with time-bound and measurable goals. Have you guys seen this at all, any of you? Okay, go to the healthdata.gov website, check out the blog, download the document. It's a very detailed and, as I said, actionable plan, which has 5 main goals. Number 1, we're going to work on making healthdata.gov more user-centered. Really design it in a better way, make it more useful for discovery, but also for collaboration. Number 2, we're going to focus on this idea of strategic data liberation. So for the first 3 years, we've really kind of taken the shotgun approach, right? Any data set that we could find, we would get, catalog, and put up there. But we want to really look at now, what are the important ones? What are the ones that are out there that we can't get, that we don't have access to yet, and put those out. Third, we want to build a real community of data users out there. And we're going to do that through education, through a number of different mechanisms. Fourth, we want to incentivize the ecosystem that exists today to use data in new and different ways than they might have done that in the past. And then finally, we're going to work on developing and implementing some policies across HHS that foster this idea of openness and transparency. So that's sort of the high level. Specifically, we're focusing on a few things. So we've talked a lot about entrepreneurs, we've talked a lot about developers over the past few years, but it's not just entrepreneurs and developers who want their data, it's patients as well. And so we're working on liberating patient data through this thing called Blue Button Plus. Do you guys know about Blue Button? Some of you? Many of you? Great. So this is actually fitting together rather nicely. HIPAA regs, you guys probably all know this, were clarified recently to essentially give patients the right to have access to an electronic copy of their data. And then also through meaningful use criteria, all of these systems out there are required to support this idea of view, download, and transmit. So all of these things are kind of coming together in a nice way. And what's happening is that we have this growing ecosystem now of patient-facing applications and tools that's starting to emerge. And it's helping patients collect their data, helping them understand it, and helping them to solve some of these problems that they've had for a long time. Just a few examples of use cases that we're starting to hear people talk about. Errors in your healthcare record. You know, this happens all the time, but you never have access to this broad swath of information to be able to correct these errors. And this is a real safety concern. So if people can go in and correct this data on their own in real time, that obviously helps quite a bit. For those of you who have kids who've ever sent them to school or camp, vaccination records, huge pain in the ass. Wouldn't it be great if there was a centralized portal where you could actually like manage your vaccination records and send them automatically to schools? Blue Button Plus will enable something like this, right? And then for any of you who've ever gotten an explanation of benefits from your favorite insurance company, you'll know that they actually don't really mean a whole lot and that they're impossible to decipher, and they could be a lot more user-friendly. And so again, this is a great use case for something like Blue Button, where you can imagine a crafty application developer being able to plug into this system, download all the data, and then actually display it in a much more friendly way than you typically get in that piece of paper that gets mailed to you or on the website. So those are just a few examples. There are literally thousands more, which I have no idea what they are. It's going to take, you know, this crazy ecosystem of developers to kind of figure these things out. But one of the other things we want to do is make it easy for people to find these applications and find their data. So the Office of the National Coordinator for Health IT in the spring is going to be launching this thing called the Blue Button Connector, which is like a catalog basically of Blue Button apps and data sources that people can go to find where they can get all of this information from. So if any of you guys are actually thinking about using Blue Button or actually have data that you are going to make available by Blue Button, let us know so we can make sure to catalog it on this site. Another thing that we're working on is working with CMS to really get their data out there in different ways. If any of you have ever requested data from CMS before, you know that this is a sort of onerous and expensive process. They know that, and what's really interesting to me is literally in the last year and a half that I've been working at HHS, I've seen a fundamental shift in their posture about how they want to get data out there. They're doing some absolutely incredible things. Right now, if you want data, you basically have to request it through this organization called ResDAC. It goes through this whole research request process with boards that, you know, privacy boards that analyze it and all this stuff. And then if you get approved, you have to pay a bunch of money. They cut the data and then literally ship you an encrypted hard drive with that information, which you can only use for that specific research request. So if you actually want to use that data again, for another idea, you have to actually go through that process all over again and get the data cut again and get it sent to you again. It makes no sense whatsoever. So one of the things that CMS just did actually at the end of last year was announce this thing called their Data Enclave, which is sort of a fundamental shift in the way that they think about this stuff. So you still have to go through a process of getting research requests approved. There's good reason for that. But instead of paying a lot of money to have this data cut, shipped to you on a hard drive, you actually just have terminal access to this secure environment where you can log in, upload your own tools, and perform the analysis on whatever data sets you need right then and there. The cool thing about this too is that the data is much, much more up to date because they refresh it pretty consistently, and it's much, much cheaper. So this is actually going to open up the world of, I think, of research and sort of academic understanding of CMS data in a pretty interesting way. So that's one thing to keep an eye out on and see how that works. If you guys have any interest in looking at CMS data or know anybody who does, tell them about this enclave. It's called the Virtual Research Data Center. Now, it's not just CMS data that we're focused on. That's a big part of it because it's such an important set of data. But we're also looking at broadening public access policies for research that's supported by the federal government. There's actually, it's kind of interesting. OSTP, the Office of Science and Technology Policy, released a executive order last year that basically said all of the research agencies across the federal government that that support over a certain dollar amount of research have to have that research publicly available within a certain time frame. Now, NIH has already had this policy for a long time. Any research over a certain amount that they sponsor, the results of that research and the data underlying it has to be made public within 12 months, published in PubMed, a whole bunch of stuff like that. But we've actually sort of taken that and expanded that across the entire department. So later this year, you'll see some new policies coming out of HHS that actually mandate this for not just NIH, but also CDC, ARC, other parts of the department that sponsor and support all of this research. And the idea here is that if we can publish all of this research that we pay for, publish the data, this is obviously going to speed up the ability for people to access that information and hopefully provide lots of new insights in rapid fashion. So we know that taking one data set is useful. We also know that when we combine lots of different data sets, that there's a massive amount of potential that gets unlocked here. And so I mentioned earlier that we were going to start looking at data as more of a strategic asset than just sort of that shotgun approach. And so what we're going to focus on this year is this idea of a strategically relevant data asset. And because we're in government, we love acronymizing things. It's the SDRA. So keep an ear out for that. Now, what this means, it's kind of interesting. So HHS, over the past year, has been developing a new strategic plan to take us from 2014 to 2018, which is going to come out pretty soon. One of the nice things about this strategic plan is that it's taken our 121 strategic goals. In my mind, if you have 121 strategic goals, you have 0 strategic goals, and actually narrowing that down to 20 strategic goals or so. Now, what's neat about that is that that 20 is a finite number. It's pretty easy to kind of comprehend and to get your head around. And so what we're going to start to do is look for data sets that are not yet released that support in some way, shape, or form the achievement of those 20 strategic goals. And for the ones that are already released, we're going to look at ways of making those even more open, right? Maybe adding APIs to them, maybe marketing them in different ways, describing them in different ways. So the idea is if we can tie the data assets that we have back to the strategic goals of the department, then this internal use case starts to get built up and people start to understand how that data is actually incredibly valuable for helping them achieve their goals. This is, I think, one of the most important things about any kind of open data program, right? You can release data externally and say, it's to enable entrepreneurship, it's to enable new development. But from my experience in actually DC, Maryland, and now in the federal government, the most value internally really comes from when people internally start using data to do their work and to manage their programs. And so I think it's an important thing to keep in mind as you kind of go down that path. The other thing that we're doing is looking outside of HHS. We have lots and lots of data, but so do lots and lots of other people. And so last year we started incorporating state data into healthdata.gov and starting to disseminate that through the same mechanisms. New York was the first. And shortly after New York, we added Colorado, Maryland, and Washington. We have Missouri, Oregon, Oklahoma, and Illinois in the pipeline. How many of you are here from California State? HHS. Excellent. I'm looking at all of you for the next one. So next time I talk about this stuff, I would love to be able to say that California data is also in this pipeline to be incorporated into here. But I want to point out kind of one thing, just to kind of get close to wrapping up here. None of that stuff that I just described, none of the last 3 years of history, none of the things that we're working on right now would have been possible without commitment. And that's both a political commitment and commitment of resources. Not a massive resource commitment, but some dedicated resources. This whole thing started in 2010 really with a memo from the secretary to the entire department laying out that this was an important thing for her and that this was something that was critical to the future of the department going forward. This was, I think, pretty necessary to get things rolling because, as you guys know, in big bureaucracies, sometimes you need that push from the top to say this is something we care about, this is the air cover, et cetera. Once that memo came out, we spent a lot of time internally building an internal network of what we call health data leads. These are people that exist in every division, operating division or staff division, but even in levels below that, bureaus, departments, whatever they're called, I don't even know. But we have lots of people that are scattered around the department that actually know where the data is, know who's putting it together, understand what it's used for, understand what it's about, and that's sort of our army of people that we can call on at any given point in time. So let's say somebody comes up to me and says, at a conference, hey, I'd love to use this data set from ACF. Well, I have a contact at ACF that I can go and find and say, hey, we would really love to get this data set out there because this person wanted to use it, and then they go and find it and help us figure that out. It would be impossible for us to actually do this on our own. So I think that network is pretty critical. We also created a full-time position in my group focusing on nothing but health data initiative. Focusing on nothing but creating this execution plan and then executing the execution plan. Those of you who have met Damon Davis, he's the guy. If you don't know him and want to meet him, I'm happy to make that introduction. Damon spends literally 100% of his time thinking about nothing but health data, and he's doing a wonderful job. So let me know if you want to get in touch with him. And then we really spent a lot of time working with stakeholders both inside HHS and outside of the department, and actually outside of government, to kind of make this thing happen. I mean, if you look at the Health Data Consortium, if you look at the Datapalooza, if you look at this world of health data that's sort of been created over the last few years, a lot of that was really due to sort of the old shoe leather adage, right? I mean, we basically hit the streets and talked to as many people as we could find and helped encourage the spread of this stuff and the actual interesting utility of it. I gave you 2 stories at the very beginning of companies that were using health data in interesting ways, but I could probably tell hundreds of those stories. But that came because of a lot of hard work from a lot of people of actually just going out there and talking. So, it might be a little scary to start this process. I was I've kind of seen it in various stages of different forms of release from different levels of government, and there's a lot of hesitation, for lots and lots of different reasons. But once you get into it, one of the things I've found is that if you're doing it for the right reasons, it tends to work out pretty well. And I would love to see California become a leader here. I mean, you guys in this state have, hundreds of thousands of people maybe who have the technical chops to be able to do something interesting with this information. And not only that, somebody wrote a while back that it was sort of disappointing and unfortunate that you had all these like really bright minds of a generation trying to figure out how to optimize click-throughs on ads. And it turns out that all of these people, if you actually give them something meaningful to work on, they would love to actually work on that, right? If they can make their home state or home city or home county or country a better place to live in, right? Or a more useful place to, a better place to find services, they will take that challenge. But we need to provide the catalyst for that. So I'm going to close with just one thought. I've got a poster hanging on the wall in my office, which is one of my favorite quotes of all time. It's a quote from the founder and ex-CEO of Southwest Airlines. His name is Herb Kelleher. And somebody once asked him about Southwest's strategic plan, and he looked at them and he said, "We've got a strategic plan. It's called doing things." And I've always found that this is the best place to start on any of this stuff. We can plan and deliberate literally forever on lots and lots of stuff and never accomplish anything. And let's be honest, we're pretty good at that in government. But if we can actually just pick a small thing, get behind it, leverage both internal and external resources, and get that small thing done, that actually starts this massive snowball effect that will really just propel you down the path of increasing returns on a lot of the effort you put into place. And this is something I've seen over time. And so my encouragement to all of you guys would be to start small. Pick something that is not that controversial, but has some potential to actually drive some value, and put some wood behind the arrow and just do it. And we're here to help. We are obviously very encouraging of anybody's efforts to do these things. So feel free to get in touch anytime. We're happy to help with advice or resources or whatever we can do. And on that note, just thank you guys very much. I'm happy to answer any questions if we have time. Do we have time? Yes, no? You have time. We have time, all right. So if you guys have any questions, I'm happy to answer them. Thank you very much. Yeah.
I'm Ivan Handler. I'm from Illinois. I'm the CIO of our Health Information Exchange. This is very exciting. The thing a lot of us have been in conversation for many years. Interoperability is one of the things, especially in healthcare, that a lot of us care about. Mm-hmm. And I understand how massive the problem is, but I'm thinking things like NEEM and others exist. I think the missing piece, at least the thing I'm concerned about, is how we make sure that we do things in such a way that we're not creating a million little silos that have some immediate value, but then when we try to go to the next level, we get stuck in the mud again in a bad way. And I think this can be done, and I know it can be done, and I'm hoping that that's one of the things that's on the agenda, or could be on the agenda, is to try to figure out how to create public interfaces in such a way that we enable all this creativity. At the same time, we don't disable the ability to interoperate.
Yeah, I agree. This is a tough problem, right? Because the vendors that exist in the EHR ecosystem in particular have absolutely no incentive to interoperate, right? Although I would argue that that's starting to change. As we move from this sort of transactional world of healthcare into more of a value-based world where providers actually need real-time data to do their jobs, you're going to start to see, I think, these systems talk to each other because their clients are going to require it. Having said that, I think there are some very, very interesting things happening out there right now. Are you familiar with the stuff that they're doing in New York in the HIE? Yeah, so I think that stuff is super cool. For those of you who don't know, the New York State HIE basically connects most of the hospitals and providers in the state. And they've essentially built a set of APIs on top of the HIE, so that if you are somebody who wants to do something interesting with health data, you basically go to them, sign a single data use agreement, and then have access to all of these standardized methodologies for pulling information out of and writing information into this network. And so one of the things that I've been thinking is if that works, it would be great to see a coalition of many states' HIEs kind of adopting these same APIs, because then the idea is if I write an app that works in New York State, then I can use it in Illinois or wherever. And so, I'm always a little hesitant for the government to be the one to specify standards. I don't think that we necessarily would do the best job at that. But what I do think we can do is encourage outcomes and then let the people out there that are actually doing this stuff build things to deliver those outcomes in a way that works for everybody. And so that's sort of where I see some of the stuff going.
I'll just follow up on that.
Yeah.
Because we're involved in that same thing. I think that it's not important that the government specify all the APIs. So that's kind of when I would like to see it.
Right.
There are certain types of things that the government really does need to regulate, especially around privacy and security.
Sure.
And if that could be done, there's possibilities of creating governance structures that involve all of them, especially on the vendors.
Right.
You could figure out the rest of the stuff. But if the government does have some clear responsibility, and I think if it could get there, that would really do a lot to enable the rest of it.
Well, I mean, we've got HIPAA and we've got the Privacy Act, right? And those things are sort of continually being interpreted and,
But their policy, we need something at a technical level so that, because that's where I think a lot, and that increases the expense, as you know.
Right.
If the government could specify something that, for the most part, technically important, but doesn't really affect the, you need something done, but whatever it is, isn't really going to affect the business outcomes, because the business has to do with the actual data.
Right.
The guarantees of privacy and security to make sure that the public is trusted is important, but that doesn't, it's kind of orthogonal to the actual delivery of services. And
Sure.
That's where I think we could use a lot more strength with that.
That's an interesting point. You know, it's definitely something worth thinking about. So let's catch up about that. I think somebody's got the mic over here.
Okay, I'll go next. Hi, Bryan. It's Jim Cashel of Forum One. You were talking about the sea change you've seen at CMS in terms of attitudes towards releasing data. But then you also talked about the current obstacles. You need research protocols approved with ResDAC. You need to actually register as an ACO before you can see claims data, you know, things like that. So the reality is it's still really hard to get access to the good stuff in a meaningful way that entrepreneurs can use.
Right.
My question is, what can outside groups, you know, governments in California, groups like Dwayne's, Health Data Consortium, nonprofits do to encourage HHS, CMS? What's a useful role of advocacy, of helping to prioritize what we'd like to see as users that facilitates the system, that helps speed the system along so the really useful stuff is really available in a way that's meaningful?
So, you know, I mean, it's a good question. It's important to point out that there has to be a balance between giving the data to people and protecting privacy, right? And that's why ResDAC and privacy boards at CMS and all this process exists, because you know, we have to be very, very careful. This is, you know, pretty personal information that we happen to hold, and it would be disastrous for this movement for a lot of different things if that, you know, information was compromised in some way that was preventable, right? So that, you know, we have to keep that in mind. Now, having said that, you know, I think that there are probably ways that the processes could be made a little bit more sort of user-friendly, a little less bureaucratic, a little faster in some cases. And so to answer your question, I think one of the things that would probably be useful is, in a lot of ways, documentation about, you know, where people on the outside world, what is the user-centered approach to fixing these problems, right? How can we leverage the experiences of people that are going through this process, going through ResDAC, getting stuff approved? What's their experience, and how do we try to make that better? Is it that things sit in one place for way too long? Can we optimize the process somehow? And I think that conversation is a really interesting one to have. I haven't heard actually too much of that. You know, I hear a lot of complaints, but I never really hear, you know, well, you know, this was my experience, and it would be great if we could do it this way instead. So I think that would be one actually pretty easy and very useful thing to do. Somebody, oh, yeah. It does matter. No.
Hi, Bryan. I'm Gordon Friedman from a nonprofit called the National Laboratory for Education Transformation. So to make this even more complex, we have an NSF grant to look at all the health, social services, criminal justice, and education systems, and how does that impact one kid? So there's no button right now that goes across agencies.
Right.
Do you have any idea, and have you had conversations at least with education and some of the other agencies in DC, especially when you get down to students who are drawing services from multiple organizations?
Well, so I think the one thing to look at is that kind of orchestrated by OSTP and the White House, there's a big push right now for every department in the federal government to kind of participate in this world of open data to the extent that HHS has. And a lot of this obviously is due to, you know, Todd obviously moving over to the White House and being sort of the steward of HHS's open data program, the catalyst behind it from the beginning, and bringing that to the federal government as a whole. Just last week, actually, there were 2 data paloozas, safety and I think education was the other one, where we're actually starting to get more of this data out there, starting to see more people actually using the data and doing interesting things with it. Now, it's still siloed, right? It's still healthcare being used in the healthcare ecosystem. It's still education being used in the education ecosystem. I think your problem is a really interesting one to try to solve, and we don't have too many people that are thinking about this across disciplines right now. I guess what I would say is that there are people in each one of these agencies that are thinking about these things. It probably takes somebody who's got a cross-agency view, or sort of an outcome-focused view that could require all of this data to bring in, to actually start thinking about how we could work together to make that happen. We're seeing this actually in some places. There's some great examples of people who are using health data that are also actually pulling in census data, lots of other things to start to build applications and make decisions. So this is not uncharted territory, but I think it's barely charted territory. So it'd be a great place to start.
Hi, I'm Paul Baker from WebEtex in Chicago, and we're the Chicago node of the Open Data Institute. You talked about plans to figure out strategically what data sets to release. In the UK, the government has started listing all, and actually in the city of Chicago also has started listing all the data sets they have,
Right,
with field descriptions and that kind of thing. And then they get input from external people which data they'd like, or they'll even maybe give you, if you need 1 or 2 fields out of one set, they may give you that.
right.
So that would be a way of not just making the decisions internally, but seeing what the outside world is looking for.
Yeah, we're sort of doing that as well. It's, we have this is where the health data leads come into play, because they theoretically know their agency, or know the part of their agency that they're in. And so they're actually out there cataloging on a regular basis what data sets exist, what the field descriptions are in those data sets, what we can put out, all of that kind of stuff. And so that's something that we're actually planning on releasing pretty soon. It's part of the OSTP, again, this is part of the open data stuff that they mandated. So it's in process as well. Basically the way we look at it is sort of in two different ways. One is, how do we look for and find data sets that are relevant to the strategic goals of the department, because this is obviously what we want to push, right? And then there's this world of people out there who says, we have all, we want to do something interesting with this stuff, help us get to it. It's been very ad hoc to this point. I get lots of emails all the time about people who say, hey, I want to get this data, help me, and we do. And so if we can make that process a little more formal, less ad hoc, I think that would benefit everybody. And that sort of gets to the point of building a community around this data use as well. So that's, it's all sort of tied together. Dwayne, I think.
Hi, Bryan. Thanks. Is this on?
Yeah.
So quick question. So when we talk about open data, we're really sort of defining it in terms of government release of data, typically from the federal government on down. How does HDI think of other sources of data, whether it's research institutions, commercial sources of data, the Fitbits and the Jawbones? I mean, has HDI sort of thought about other sources of data and how maybe it fits into a broader open framework?
Well, as I described, we're talking to various entities that are outside of HHS, state agencies in particular, the UK government actually in certain cases, to see if we can incorporate that data into healthdata.gov and the overall discovery framework. I do think that there's a much richer ecosystem out there, but it's, I would argue, lower on the priority list than the things that I mentioned that we were focusing on. Having said that, if there are interesting use cases and somebody comes up to us and says, hey, we want you to catalog this data, or we'd like you to work it into your plan somehow, we would definitely consider that. I mean, it's a rich world out there, right? And there's all kinds of information to collect and catalog. And if we can help be sort of the centralizing force behind that, we're happy to do so. So if you have suggestions, bring them on.